Assalamu alaikum. Good afternoon to all of you. My presentation is on gestational diabetes. This is carbohydrate intolerance discovered or diagnosed for the first time during pregnancy. It affects about 7% of women, and the benefits of treatment and the risks have all been well established, but there is a lot of controversy upon how, when, and how to screen for diabetes during pregnancy. Maternal risks include hypertension, preeclampsia, higher incidence of operative delivery, both instrumental and cesarean delivery, trauma to the birth canal, and future development of type 2 diabetes in about 50% of cases in about 10 years' time. The most important fetal risk is macrosomia. Large babies, macrosomia, that is a birth weight more than the 95th percentile for gestational age, lead to a lot of complications, including birth injuries, whether bone fractures, shoulder dystocia, or even organ damage. Also, there is increase in operative delivery and neonatal problems, including hypoglycemia, hypocalcemia. And it was found out in most studies that macrosomia increases both the maternal and fetal and also the neonatal risks. The larger the baby, the more possibility of preeclampsia and hypertension, the more possibility of birth injuries and even neonatal complications. Also, there is a higher perinatal mortality, especially with fasting hyperglycemia, more than 105 milligrams per deciliter, and with severe obesity. In a survey done in 2008, it was found that 96% of obstetricians would prefer universal screening. And with this policy, a very few number of patients or percentage of patients will be excluded. These are the patients who met all of the following characteristics: an ethnic group of a low prevalence, no diabetes in first-degree relatives, less than 25 years of age, normal weight before pregnancy, and no history of abnormal glucose metabolism or poor obstetric outcomes. On the other hand, selective screening is a targeted screening, which means more cases would remain undiagnosed. And basically, this screening policy is directed to women at risk to develop gestational diabetes, and these risk factors include a prior unexplained stillbirth, a prior infant with a congenital anomaly, previous macrosomic babies, previous gestational diabetes, family history, obesity, and more than 35 years of age. The most important two risk factors in this list are obesity and previous gestational diabetes. Obesity and previous gestational diabetes really put the woman at high risk. So next comes the question of when to start screening. 24 to 28 weeks has nearly been established as the proper time to start screening for diabetes. But in the presence of high risk factors, those listed below, obesity, strong family history, previous history of gestational diabetes and impaired glucose metabolism or glycosuria, it is really accepted that screening should start earlier in pregnancy. And if the screening test is negative again, it should be repeated at 24 to 28 weeks, or with the development of any symptoms or signs suggestive of diabetes. There is a lot of controversy on how to screen for diabetes. In some countries, the one-step diagnosis is the preferred method, but in other parts of the world, a two-step approach is the cause. In the one-step diagnosis, there is a 100-gram oral glucose tolerance test done for women early in the morning after an overnight fasting of at least 8 hours, but no more than 14 hours, following 3 days of unrestricted diet and usual activity, and the patient should remain seated and not smoking during the whole period of the test. The venous plasma glucose is checked at fasting and after 1, 2, and 3 hours. 2 or more values must be met for the diagnosis of gestational diabetes. It was also found that even with one abnormal reading, if proper diet and exercise are employed, it really improves the outcome and prevents a lot of complications. In some parts of the world, these are the values used for the diagnosis of gestational diabetes, but in other parts of the world, lower values are used. With stricter criteria, the incidence of gestational diabetes is increased by about 50%. So these are the figures used by most countries at the moment, but I will pause here for a few seconds to explain about the HAPO study. The HAPO study is a multinational study, and the results were published in 2008. HAPO stands for hyperglycemia and pregnancy outcome. In this study, it was found that the incidence of macrosomia and perinatal morbidity and mortality are increased even with values of blood sugar less than these stricter values. And the 5th International Conference Workshop on Gestational Diabetes refused to take or to employ or to adopt the values found by the HAPO study. But in February 2015, that's only 3 months ago, the NICE guidelines adopted the HAPO study results and started to use even lower values than these values here for the diagnosis of gestational diabetes. And it is expected that with even stricter criteria for making the diagnosis, the incidence of gestational diabetes will jump up to about 20%, making it one of the most common medical complications encountered during pregnancy. On the other hand, the two-step diagnosis, which is used in the United States, and in few studies it was found out to be more cost-effective. They start by checking 1 hour postprandial blood sugar after 50 grams of glucose. And if you use the cutoff value of 140 milligrams per deciliter, then the sensitivity is 90%, and 15% of patients will require a full glucose tolerance test. And if the cutoff value is 130, then the sensitivity is nearly 100%, but 25% will require a glucose tolerance test. Without or outside the context of the oral glucose challenge test, a random reading of 200 or a truly fasting level of more than 126 makes the diagnosis of diabetes established without the need for further investigation. The treatment of gestational diabetes involves a team approach, and the dietitian role is very important. It should be individualized, but the general plan is to give 3 meals and 2 to 4 snacks a day, and the caloric requirement is 30 kilocalorie per kilogram per day, plus minus 5 kilocalorie per kilogram per day for those who are underweight and overweight. And the composition of the diet should be 40 to 50% of carbohydrates, 20% protein, and 30 to 40% fat. It is very important to check the urine for morning ketonuria and increase the caloric requirement if there is morning ketonuria, because it has been linked to psychomotor impairment in offspring. These are just some examples for what food to be ingested by women with gestational diabetes and what to avoid. All to avoid hyperglycemia, which is linked to all the complications mentioned earlier. In very small number of studies, exercise was found to be very useful. It improves the glycemic control when combined with diet, than diet alone. And yes, the oral hypoglycemics can be used during pregnancy, safely during the 2nd and 3rd trimesters. Even glyburide was tried in studies from 11 weeks onwards. Start with a small dose and increase gradually according to the glucose level. But 10 to 20% will fail to meet the criteria of good control or euglycemia. Metformin is a medication used in PCO patients, and when they become pregnant, if they continue on taking this medication, it does reduce the incidence of miscarriage and gestational diabetes. Unfortunately, failure is more with metformin, and glyburide gives better results in terms of blood glucose level. Historically, insulin is the best anti-hyperglycemic medication, and the dose is adjusted according to the body weight and according to which trimester during pregnancy. There are so many types of insulin, but the intermediate acting and short acting have been tried safely during pregnancy, and they are used according to the common schedule, 2/3 in the morning, 2/3 of the dose intermediate, and 1/3 is short-acting insulin, and 1/3 in the evening, half of the dose is intermediate-acting and half is short-acting. The insulin Lispro and Aspart, the insulin analogs, are preferred nowadays, and they have been used safely during pregnancy. They are associated with less incidence of hypoglycemia. Fetal well-being should be by non-stress test and on regular basis, starting at 40 weeks in diet-controlled patients and earlier for those on medications. Fetal growth by ultrasound is very important. There is no agreement upon the best time and method to deliver these patients. However, cesarean section is indicated if the baby is more than 4.5 kilos, and if fetal weight is between 4 to 4.5, you have to consider other factors, especially the previous obstetric history and the pelvic capacity. For those controlled by diet, they may go up to term and consider induction at 41 weeks, but those on anti-hyperglycemic medications should be induced during the 39th week to avoid the higher possibility of perinatal mortality. During labor, blood sugar should be kept between 7 and 110. There are so many protocols how to use insulin and glucose during labor, but one of the simple protocols to follow is to just add 10 units of regular or short-acting insulin to a 1 liter of 5% dextrose, normal saline, with infusion rate of 100 to 125 milliliter per hour. Of course, the capillary blood sugar should be monitored during the induction process, and it should be every 2 to 4 hours during the latent phase and hourly every hour during the active phase and when insulin infusion is used. However, patients on diet only, without medications, need to check their blood sugar every 4 hours. It is recommended to check the fasting and postprandial before leaving the hospital and to repeat a formal glucose tolerance test with 75 grams glucose load at 6 weeks postpartum. The aim is to keep the fasting below 100 and postprandial less than 140. And if normal, they should be checked on regular basis, minimally every 3 years. Those patients should be encouraged to exercise and to lose weight, because this will avoid the future development of type 2 diabetes and the metabolic syndrome. The low-dose pills are safe to be used by diabetics. Actually, they are preferred than the mini pills even. The combined low-dose pills are better than the mini pill to use in these patients, and it does not increase the glucose level. And if there is any contraindication, IUCD can be used. Thank you very much.